The finalists who are going to be presenting in the final round. In the meantime, I would just invite all the judges here. Dr. Maipal sir, Dr. Ashok Grover sir, please sit on the front row, sir. Dr. Debashish sir, Dr. S. Natarajan, Dr. Avinash Patange, Dr. Meenu Mathan, Dr. Guru Prasad, Dr. Gopal Arora, Dr. Gaurav Luthra, Dr. Vivek Dave, Dr. Sri Ganesh, Dr. Jignesh Taswala sir, please come on the first row. So I'd also like to invite the chairman, Dr. Harbansh Lal sir, co-chairman Dr. Lane sir, convener Dr. Ajay Paul, co-convener Dr. Kumar Doctor sir. So we have had the 4 prelims already through the day, and we have had excellent sessions, and each of those speakers were so wonderful, and there have been excellent and novel ideas. Now let's see which of them actually reach the finals, and then who finally gets the winning cup. So it's the last few minutes to wait, and then at the end of this session we would be knowing the winner, and that would be revealed only at the valedictory function. Yes. Debashish sir, please welcome. Please take a seat. So we are waiting for the list, which Dr. Chitra madam will be handing over in the next. Right now it's empty. Can I have these scoring sheets, please? Yes. Are all the speakers already here? Whoever was there in the morning? Most of them appear to be here. Yes. No. Giving a talk in some session. In the next few minutes, she would be coming and she would be giving. So we are waiting for the list from her. So she has all the reins in her hands. Dr. Prasanna Venkatesh. So I'll read out the names of the speakers so that you'll know. First, Dr. Prasanna Venkatesh Ramesh, Dr. Prabhu Bhaskaran. Big round of applause for all of them. Dr. Arvind Moria, Dr. Avdesh Oli, Dr. Shruti Deep, Dr. Surbhi Agrawal, Dr. John Davis Akara, Dr. Prithvi Chandrakant, Dr. John Davis Akara again for his other talk, and Dr. Shivraj Tagare. And Dr. Kunal Mandlik and Dr. Prithvi Chandrakant. So let's start with the first talk. Dr. Prasanna Venkatesh. Second is Dr. Prabhu Bhaskaran. Please be ready with your presentation also. Are all the speakers whom I mentioned here, if they are all in the room, please raise your hand so that we know. Yes. Dr. Moria, I can see. Dr. Prabhu Bhaskaran. Yes. Dr. Avdesh. Okay, first 5 at least.
Everybody has it.
Yes. Can you please set up their slides? Dr. Prasanna Venkatesh would be speaking on the new age application for ophthalmic pedagogy and counseling with 3D reality.
Can I have my slides?
With the timer also. Yes. Yes, all the judges, please note, please mark for all the speakers. And even the discussion can be taken by anybody, but it would last for 2 minutes per speaker. No particular discussant, because this is, 4 minutes speaker, 4 minutes presentation, and 2 minutes of discussion. No specific discussant, but we will limit it to 2 minutes.
You want to speak second then? Okay.
Are you ready? Right. Please start. Yes. Please keep the timer on.
Yeah. Can I start, ma'am? Start? Yeah. Thank you for this wonderful opportunity. I'm going to talk on my application IMG-AR, which is an augmented reality application for pedagogy, diagnostics, and counseling with augmented reality. So I'm Dr. Prasanna Venkatesh, and the mission of mine was to enhance pedagogy, diagnostics, and counseling in 4 dimensions using patients' real-time, high-resolution scan images what we get from them. For me, 2D seemed to be slightly not great, so I thought if something is presented to me in 3D, I get the grasp of it much better. But why not 4D? 4D, we have the ant tracker as well. So got inspired from this Marvel Cinematic Universe where Iron Man uses his holograms to go about his things. So why not we ophthalmologists also upgrade, rather than a science fiction movie, it's a science-based reality, and we innovated the holograms in ophthalmology. So the problem statement was, if you see OCT and fundus, they are separate from each other. We don't have them interfaced or interlinked. So see this video here. In our holograms, the fundus and the OCT are one above the other, and we can choose the different sections and different slices of what layer we want to actually see and diagnose the patients in 4D, 4 dimension. That's all our software is about. You can see actually here the user is using this headset and moving about in free space. But in front of him, the patient's case sheet is in 4D. The color fundus, the infrared, the autofluorescence, the cranial nerves, the cerebral structures, everything can be generated in 4D and the diagnostics can be made. So he's actually now using his hands to now track the eyeball, to expand the eyeball. If you want to be the gonioscopy, it can be done. The Miyake Apple view, lens examination, and also the gonio structures, we have also added the electron microscopic view as well if you have much better zoom. So all these are possible, and along with that, fundus examination. So this is examining the case sheet of the patient in 4 dimensions. So this is the workflow. Imagine a diabetic patient walks in, the fundus and the OCT is taken and he has cystoid macular edema. The data goes into the hospital data set. Our translational software converts it into hologram under 60 seconds with no chair time. And not only that, from the fundus, we can choose the slice. So whichever you want, the choice of slices can be selected and the diagnostics can be made. It's also useful for teaching and counseling as well. So once the diagnostics have been made, this immersive experience with the headset can also be given to the patient, and counseling can be done in 4D. And you can see that now after treatment with the PRP dots and anti-VEGF injections, how much the edema has come down, again can be shown in the patient also in 4D. So this is about diagnostics, counseling, as well as for pedagogy for neophytes. So after treatment, now again the patient is counseled. For anterior segment imaging, again the anterior segment OCT, the posterior segment OCT can also be made as holograms, and a posterior polar component can be evaluated before surgery and can be planned. If you ask me, only is there in headset? No, it's also there in a mobile phone, which is free of cost, what we have given here, and this is the QR code, my dear friends. So here you can see the holograms seen in the mobile phone, and also it can be accessed, which is made available for all. So augmented reality eyeball models are there, the cranial nerve models have been provided. The unique feature is we have used real-time gonioscopic structures, slit lamp structures, fundus structures, and we also published it in Indian Journal of Ophthalmology. To summarize it, it's a patent-protected technology. We have filed the patent. It's a 4D diagnostic tool, 4D telemedicine and 4D artificial intelligence is possible with it, 4D multimodal imaging with color fundus, flecked retina, low vision rehabilitation, counseling for retinitis pigmentosa, useful for neuroanatomy pedagogy. So you can see that all the complex neural structures from cranial nerves to extraocular muscles have all been created for pedagogy. So this is what it's all about. Augmented reality is going to be the future, and it is no more a science fiction. It's a science-based reality. Thank you.
Fantastic.
Thank you, Dr. Prasanna. Congratulations to be selected for the final.
Can we ask her a question?
Yes.
Do you have to have that headset always with you for having the 4D augmented? Yeah.
Yes, sir.
And what is the cost?
So the cost of this headset comes approximately 2,000 INR, 2 lakhs INR. So the thing is, since this headset was limiting and we were not able to penetrate to every user, we have created the same app in an Android phone as well. So with the QR code, and it is available free of cost, it can also be available in Android phone as well, sir.
Wow.
So people who want to have an extra perception, headsets are there. But now for availability to every individual, a simple QR code in their Android phone, we have made it available, sir. So it's in multiple platforms. Yes, sir.
Yeah.
No, if it is an Android, sorry.
Yes.
Yeah, please go on. No, if it is in the phone, how do you get this 3D? This one?
Sir, if time permits, I can demonstrate.
No, that's okay. Is it possible?
Yes, sir. The phone has to, currently every phone has a configuration of Nougat 7.0. So what happens is, just like how we open the phone and we get the Bugs Bunny's headset, or we have a coolers, similar concept, we have created this AR template. So this is our intellectual property, and once automatically when you throw the phone over this particular template, so you get the eyeball model of that particular patient and you can choose the case sheets of the patient. So a patient walks in, you do the imaging. Ours is a translational software which converts it into a hologram. The idea is by rotating this paper, you can access 360 degree, or you can take your phone front and back for a more magnified view. If you want the gonioscopic view, you will have to slightly bend and go forward. Maybe I can demonstrate to you if time permits also, I can do that also.
If I can quickly ask
Yes,
one
sir.
excellent presentation.
Thank you, sir.
What is the basic set of imaging that is required, and would you require to repeat it at every visit before this sort of an evaluation is done?
Sir, I would recommend to repeat the investigations, especially when therapy is being advised for the patient, because at follow-up, this is just an extra edge that we get. Because eye being a three-dimensional structure, we are actually examining the eye in 2D printouts as well as in 2D case sheets. At least it's time that we need to move into 3D. So just like every visit, I would recommend it if it's possible. Or if not, at least once in a year or every major visits when the patient comes, we can recommend this, sir. So that we don't have any blind spot in the area. Just imaging the 3D structure in a three-dimensional way. And we have brought the 4D element with the hand tracker as well.
Thank you, Dr. Prasanna. I
Thank you,
think we have had the complete discussion. Thank you so much. Dr. Shruti Deep would like to speak ahead of her line. Yes, please start with your presentation. She would be speaking to us on a novel wearable device for dynamic measurement of sunlight in children. Please note, all the judges, you need to mark for all the speakers.
Where is the timer?
Timer,
We
please.
cannot see the timer
Actually,
anywhere.
the timer works only on the conference laptop. If the speaker uses his own laptop, the timer doesn't work. So unfortunately, we don't have that. Can you keep the time, please? Yeah, because they are using the conference laptop. If the speaker uses his own laptop, then unfortunately that doesn't work. Exactly. Who is the timer here, official timer? Can somebody please tell when the time is up?
Just raise your hands.
No, please just say time up. There is a timer here. I don't know why. No, but that's not really working properly. That's not working. AV team, please, if there is no timer and they are using their own laptop, please just speak up that your time is up. Okay? Thank you. Yes, Dr. Shruti.
Second speaker.
Sorry, sir.
Yeah, that is what
Yes,
everybody is asking. In time,
Yeah.
because that is time also, na?
Yes,
Ask
yes.
for time.
He was on time.
Yeah.
Yes.
Okay. His video was 3 minutes 58 seconds. So, yes. Okay. Shall we move on? Yes, please. Shruti is, yes.
Yeah, 80-18.
AT18. Yes,
Yes.
yes, yes.
Yeah.
Okay.
Start, please.
Good evening, everybody. Imagine this beautiful landscape. Now imagine seeing it this way. And imagine 50% of the world seeing the world like this by 2050. This is myopia for us. This has grown to become a pandemic along with the coronavirus over the last 2 years. And this is not just globally. Even in India, we are all set to reach 50% by the year 2050. Now that's staggering. Is there anything we can do to stop this? Yes, there is hope on the horizon, and that is sunlight. Sunlight has been found to have a beneficial effect in protection against myopia. But there are some factors which we still do not know. What are the protective factors? Is it the ultraviolet? Is it the sunlight? Is it the physical activity or the heart rate? Our question is the only way to actually find out how well the sunlight exposure is happening. Is that the only way we can find out? And how can we promote outdoor activity to the parent and a child in a real and dynamic manner? To answer all these questions, we came up with this new innovation called the Luminous Sundial. Now this is a wearable device that can be worn on the wrist or any other part of the body with the right adapter. Now this device has an ambient light sensor on the top and a heart rate sensor on the back. It's fairly fuss-free and easy to handle. Now what is the kind of data that we can harvest from this device? First is the illuminance levels with lux through the ambient light sensor. We can also measure the UV exposure, the infrared exposure, the physical activity through an accelerometer, heart rate, the ambient temperature, and putting all of this together, we form thresholds for overall outdoors time in minutes. So that's the most important part of this. The sensor collects the data from the sun and stores it on the device. 1 minute, one reading is taken, so over 1 hour, 60 readings can be stored. And all these readings can then be synced to a mobile phone application. And through that, you can see this is how the interface looks. And on an everyday basis, on a 24-hour graph, you can see the actual ambient sunlight exposure for the child. And we can even set goals for the child in terms of steps and sunlight exposure. So the first part of what we did was to validate the device against a standard luxometer. So we placed 8 devices and we validated it against a luxometer, and we found the correlation coefficient to be 0.786. Now the next thing what we did was we went ahead and placed them in 4 different settings, each for 7 days. So 7 days in outdoor direct sunlight, 7 days in shade, 7 days under an indoor near a window, and 7 days in artificial illumination. Now what we did was we put all of their data into a 24-hour graph such that each value that comes is an average of 3,360 values. So when we put that across in for visible light, we saw the maximum was 30,000, whereas in indoor artificial light it was 10.8. It was statistically significant between direct sunlight and outdoor shade, as well as statistically significant between being near a window and artificial light. Now the next part of it was the ultraviolet light, which formed a similar pattern, more in direct sunlight and least in the artificial light, and same for the infrared light pattern. Now what we did find out was, in earlier studies, 1000 lux was taken arbitrarily as outdoor time, but what we found out is in some areas of outdoor shade it was less than 1000, and in indoor natural illumination it was more than 1000. So to provide real-time data, we put all of our data into machine learning, and through the Python software we put 60% in testing, training, and 40% in testing, and we found out that the device had a really good reliability of 67%. So the device is able to give us real-time output as to whether the child is indoor or outdoor. We then went ahead and tested it on 10 kids, and we found a good compliance of 83%, with 80% giving excellent feedback, and the average time spent outdoors was 1.2 hours in the holidays and 38 minutes in school days. So this is a reliable measurement of sunlight exposure. To the researcher, it's a pivotal research tool. To the clinician, it actually helps us customize myopia control, and to the parent and the child, it gives an active feedback promoting outdoor activity. So these are my references. I have a lot of people to thank for this project. And this is a picture of me when I was a child, and this is a picture of my children today. And I think we need to bridge the gap by bringing sunlight into our homes. Thank you so much.
Excellent, Dr. Shruti. Congratulations for being selected in the finals. Guru Prasad sir, would you like to ask a question? Anybody from the judges?
This wearable is on the wrist?
Yes, sir. So we have 2 adapters as of now. One is on the wrist, the other is on the ID card, because some of the schools don't allow watches. So even on the ID card, we have an adapter that can be fixed. In fact, it can be fixed on any part of the body with the right adapter. So we're making new adapters now.
See, I asked this because basically you're looking at the UV light and sunlight hitting the retina, right?
Right.
So when you wear a wearable on the wrist, and if the child is wearing a hat or a cap, then it's different. The UV reaching the wearable is different from the UV reaching the eye.
Yes.
And it can be totally different. Like you showed in the shade, it is different from when the child is exposed directly to the sun. So ideally the wearable should be somewhere near the eye, maybe as a
level
spectacle
of
or something
glasses,
like that,
yes.
rather than on the wrist. Isn't
Yes,
that?
absolutely, sir. So there, we are looking at kids with glasses and without. The ones without glasses, we are looking at these adapters. For the kids with glasses, we are now trying to make adapters to fit in the glasses itself.
And the target population should be without the caps or any headgears.
Absolutely, sir. So we are now in the clinical phase where we've given 10 devices out to myopes, 10 devices to non-myopes. We are following them up for 6 months and to see how the lifestyle actually alters their
Did you
refractive
find
error.
any significant difference as of now, maybe in a pilot study, between those getting adequate UV versus those not getting adequate UV when myopia progression is considered? Because because it's multiple factors, including
Absolutely.
nutrition, etc., genetic factors.
Yes,
and
sir.
all that. So
Yes, sir. It's a complex disease. We still don't know actually what is it. So I hope this device gives us some information. We have done 1 week study, which is the wearability study, sir. That's the result I put out now. We are looking at the 6-month data, sir. So maybe I'll be able to answer your question with the next part of the study
So
results.
you still don't know the clinical application.
Absolutely, sir. It's
Was
going
it the exposure time outdoor activity that was that was measured, or was it the exposure of the eye to the light that was measured?
No, sir. This part of the study which I have presented is calibration, validation, and variability. So we've calibrated it, we've validated it, and now we have tested it on kids to see whether they're wearing it, and we've measured the average time spent outdoors. So the average time spent outdoors we have measured through thresholds. So what we have found out is if we keep it at 1000 lux, sometimes we end up measuring the indoor time. So that's why we did machine learning to define outdoor and indoor. And based on that, we found that in 1 week using of the children, 1.2 hours during holidays is what the average time they spent outdoors, and 38 minutes during the weekdays.
What would be the cost of the device? Did you look at it?
So right now it's in the prototype stage, sir, but we're looking at aiming anywhere between 3,000 to 5,000. That's where.
He's the speaker. Thank you so much, Dr. Shruti.
Thank you, sir. Thank you so
Our
much.
next speaker is Dr. Prabhu Bhaskaran. He would be speaking on a novel suture thread device for easy scleral fixation of a multi-piece intraocular lens. The next speaker, Dr. Arvind Maurya, please be ready with your presentation.
Good evening, one and all. Can I have the presentation?
The AV team, please give his slides. And also the timer.
Yeah, Dr. Prabhu. No, not this one. The other one, other folder.
For ease of understanding, the next three speakers, Dr. Arvind Maurya, Dr. Avdesh, and Dr. Surbhi Agarwal, please be ready.
Prelims 1.
Yeah, so that.
Congratulations to all of you.
Have they identified your folder?
Yeah, the opening. Yeah. So whenever we think of esophageal surgeries, these are the names that would pop up in our mind. Geba Shariat, it has got a steep learning curve because of the zero working distance which he has conceptualized. The sclerotomy point and the starting point of the scleral groove are almost the same. So it's a challenge. So then Amar Agarwal in his glued IOL, he simplified the technique by increasing the working distance by shifting the scleral groove slightly away. But it requires an expensive glue. This Emanuel's technique, a flange IOL technique, though, although it's simple, it has got a significant reduced intrascleral haptic length. So why can't we thought of, the slides are not moving. Yeah. So why can't we have a technique which is simple, cost-effective, at the same time can achieve adequate intrascleral fixation? That's when we thought of this. That's when we thought of this device, S-Fix or suture-guided haptic fixation technique. So it has got three components. So it has got a polyamide tube, which is hollow, cannulated, the yellow color portion, which is connected to a 5-0 nylon suture, which is to the other end, it is crimped to a 380 micron, customized spatulated needle. So there are four important steps. This is the first step, the docking. You dock the exteriorized haptic into the lumen of this polyamide tube. You dock it till it reaches the suture filled portion. The second step, you push it inside complete till the polyamide tube completely goes inside the eye. The third step is suture bite. So you take a bite very close to the sclerotomy point, which is very crucial. Then you go around 2 to 3 mm or the sclera and then exit. The fourth step is simply pull it. As you pull, the haptic will simply follow the suture track that is being created by the suture needle. So these are the 4 steps of this technique. You repeat on the other side. So let me demonstrate with the surgical video. You can see the first step, I'm docking. You dock it till the haptic reaches the suture filled portion of the polyamide tube. So then the second step is you push it inside. Once you're convinced that it's docked well, you push it inside. You push it till the yellow portion, the polyamide tube, completely goes inside. That is the second step. So this junction between the suture, nylon suture and the polyamide tube is very crucial. We have given adequate strength to it so that it doesn't give away. It takes the entire load, entire resistance that it has to face through the procedure. The third step is suture track that you're creating. This is a customized 380 micron spatulated needle. It's going to create a very sleek scleral groove of 2 to 3 mm. Scleral groove is made with the needle. And then you simply pull it. This is a 4th step. As you're pulling, you can see that the haptic is going to simply follow the track that's being created. Sometimes when you pull, little bit of haptic can be seen outside. Yeah, you can see the polyamide tube is coming out, the haptic is simply following. You can see a little bit of haptic, absolutely not an issue. You can easily push it inside using McPherson forceps. You may trim it also, but I prefer to push it inside so that it gives me scope for titrating the IOL at the end. So repeat the steps on the other side. Docking is the first step. You dock it till it reaches this point. So the polyamide tube has got two portions, suture filled portion 4 mm and hollow portion 4 mm. Yeah, the second step is you push it inside. You push it inside till the polyamide tube completely goes inside, intraocular, because it's slightly stiff, so it doesn't bend much. So you push it inside, no worries, it will not give away. The third step is suture track, 2 to 3 mm. As you can see here. Yeah. So, yeah.
Thank you so much, Dr. Prabhu.
Yeah, this gives well-centered IOL.
Yeah. Judges.
What is the cost of the suture and is it commercially available or still?
Not yet. This is not commercially available as of now. We are in the process of doing it. We are working on the results and very soon we'll be coming up with.
It's a non-absorbable suture that you're using with a halo dressing or?
Suture is not going to stay, sir.
So it's going to come
yeah,
out
it's
anyway.
just for the procedure.
Now, Prabhu, you are that polyamide hollow thing, you are putting it in the haptic.
Yes.
Which has been externalized.
Yes, sir.
Okay.
Yeah.
So, I mean, most of the job is actually done. So, what are we doing actually?
So the issue is, tucking in the scleral fixation. Sometimes it becomes a challenge because of the, working distance, and or you need special, consumables like glue or creating scleral flap. And as I said, the flange technique, although it's simple, it doesn't give you adequate intrascleral length. It somehow it acts like 2-point fixation, which can result in tilt of the IOL or the long-term instability of IOL. So this is something which is very simple, cost-effective. At the same time, it achieves adequate intrascleral haptic fixation.
How many cases you have already on this?
We have done around 30 to 35 patients. We are working on the results and we are in the process of
In all cases, the IOL is very stable.
IOL is pretty stable.
The way we have in Yamana, we try and cauterize the tip. Yeah. You don't advocate in this because you feel that length is sufficient enough for stability.
Yeah. Here we achieve good intrascleral length. Yeah.
Did you have any pupillary capture?
Not really.
Because Yamana, you can have pupillary capture.
Yeah.
So, and did you look at the effective lens position? Where does the lens sit? What is the effective lens position? With this technique, what is the ELP?
So the lens position depends on the sclerotomy that we create. We recommend symmetrical sclerotomy points, 180 degree apart and 1.5 millimeter away from the sclera. If you can take care of that part, tilt should be extremely minimal.
No, not tilt. Tilt, you said you didn't have any capture. Did you measure tilt?
Not really. Yeah.
You didn't measure tilt, so you don't know if the lens is tilted or not.
Yeah, clinically, but measured in few patients, but not in all patients.
How did you measure tilt?
Doing AIOS and we measure the distance between the IOL and the iris plane, and we compare the change.
And there is no.
Did 30 cases, did you look at the ELP? Because ELP is important for the refractive outcome.
Yes.
So if your technique has a predictable ELP, then it would have a predictable refractive outcome. So that's the reason why I asked whether you actually measured the ELP and what was the ELP.
That and also the vault in case it is made.
Another question, what's the diameter of your polyamide? I mean, if it's holding on to the haptic.
The inner diameter is 200 microns.
And so what's the diameter of a haptic?
Roughly around 160 microns.
Because it can slip. Has it ever slipped?
No, it will not slip. It will not, whatever we have done so far, it did not slip. The reason is one, it's a snug fit because of this 200 and 160. Another thing is a polyamide tube is a straight thing, whereas haptic is a little bit curved. So when you can dock the curved thing into straight, it gets really,
No, you use only one IOL or different types of IOLs also? Because haptics come in different sizes, different IOLs.
We have used a sensor and Aurolab 3-piece IOLs.
Okay, no cutting conjunctiva, no here?
No,
cutting
it
the
can go
needle.
transconjunctival.
So where do you take the bite? Because this comes out through a transcleral sclerotomy.
Yeah, your bite should be very close. In fact, at the bed of the sclerotomy point. So if you can take care of that part, it can come absolutely. It will go transconjunctival. But in the beginning cases, even I would open the conjunctiva and take a scleral bite. Once
initial cases we should suggest that. Otherwise, it will some part.
Yes. Once you're comfortable, then you can go transconjunctival.
Taking the scleral bite is a blind procedure. You don't know how deep you are in the sclera, right? Did you measure whether you had perforated the sclera in any case?
It's like taking scleral bite. Otherwise,
but when you take a scleral bite, also you can have a perforation in the sclera.
Yeah.
So that's the reason why I'm asking. Did you look at the depth and whether you had any perforation?
Yeah, I have AIOS. We are looking at AIOS on the post-op. In fact, my last slide I could not show, but haptics are well stable.
All of them were
Yes.
None of them went.
No.
Thank you, Dr. Prabhu. Like to invite Dr. Arvind Moria for his presentation. The next speaker, Dr. Avdesh, please be ready with your talks. You had 2 talks. Out of that, this talk would be new needle for suprachoroidal triamcinolone injection. Yeah. Dr. Moria, congratulations for being selected as a finalist.
Thank you, ma'am.
Yeah, can we have your slides, please? So he would be speaking on smartphone annotation tool for image labeling for artificial intelligence in diabetic retinopathy.
Hello everyone. Thank you ARC for the opportunity. Myself Arvind and I will be speaking on a smartphone annotation tool for image labeling for artificial intelligence in diabetic retinopathy. We initially began by asking doctors to annotate the images using online platforms, but face some of the following issues, like volume of the data increase over time and less portability because of desktop sites, long image loading time due to weak internet connections, ever-changing disease schema, and as we kept on receiving some new data from hospitals, we could not upload to these tools as it may violate patient data privacy laws. This led us to develop our own in-house image annotation tool. As seen in the video, adding in annotations for an image is pretty easy. View the image, magnify it, change the brightness, change the contrast as needed, click on the relevant option, choose the extra details, and the annotation is saved. The analytics on the landing page shows the pending and completed images. The graph shows the maximum number of images stacked by the other users in real time and gave the daily target settings. These imaging data sets are generally in the range of thousands and can be overwhelming for a single person. So we chunk them into sets, each containing 1,000 images or less, which a grader can very well complete within 2 weeks. The issues mentioned earlier were resolved as follows. For faster image loading, we resize images into smaller size thumbnails with a smaller memory footprint while still maintaining the visual quality. We leveraged the asynchronous capabilities of the browser and didn't load just 1 but 3 images preemptively so that the grader doesn't need to wait for the next image to load. And the initial interface was basic and evolved based on the grader feedback. It is now designed on a decision tree structure to render the nested sub-classification and extra options. Finally, on the developer's end, we managed to doctorize the entire application and deploy it using the Kubernetes platform. We have seen a total behavioral change where on the online tools, the grader used to work only on the weekends, but on our tool, we have a logged uses and all the days of the week. Average time taken to label a single image reduced substantially. We validated the AI algorithm developed using annotations on this tool on some new testing data sets and found them to have a really high performance scores. This strengthens our hypothesis that this tool is not different than the desktop-based tools and with added benefits of being portable and flexible. On the basis of satisfactory levels of verifications and validations, we are developing a smartphone-based app on a binary system of referable or non-referable decision for the retinal disease. On this unique convolutional neural network-based algorithm, on feeding a retinal image, it undergoes multi-level screening to provide a diagnosis in less than a minute to decide whether referral is required or not. Also, there is a color coding to decide between a normal light green cold zone and an abnormal red hot zone, along with a specific measurement of various biomarkers like in glaucoma for referral. and hopefully very soon it will be available on Google Play Store. We wish to introduce more gamification, label optimization to be used in telemedicine. With some minor tweaks, this tool can be easily adapted to work for other domains as well, such as anterior segment telemedicine, radiology, dermatology, etc. Thank you. Thank you. Jai Hind.
Just 1 minute. I think I have to go because there are 2 places I have to go now to hand over the completion certificate and the quiz. So because the session's been running late, I have to go. But I wanted to thank you all judges for being here today and conclude it. And Anaga would take the scoring sheets from here. Thank you very much.
I have to write the names of the judges.
You have to name of the judges here. Yes.
May I ask? Yeah, nice presentation, Dr. Maurya.
Thank you.
I was trying to understand, is this something that will have an application in predicting a future fundus photography with respect to what is the disease? I mean, what exactly is the aim?
We are here to replace IDXDR very soon.
Okay, so in your experimentation or in your work that you've done till now, in the images where the thing has gone wrong because you have a level of sensitivity and specificity, what was...
89%.
So what was that 11%? Were they ungradable quality of images or some specific pathology which was being not flagged correctly?
It's because of the image was not good, and we have a lot of features like zoom is there. Right, and there is this contrast and brightness slider is there. We can even magnify the image as shown in the video. So we can make a lot of images which are ungradable to gradable.
Thank you.
What are the scalable challenges?
First, to get the data. That was a big challenge.
That's universal for all AI-related instruments.
Yeah.
So what are very unique for your app? Not perceived, not related to AI, but what is unique for the tool which you are building?
It's an offline. It will work in offline mode also.
No, I'm not talking about.
It's portable. It's flexible.
Challenges required or challenges you foresee while scaling up.
Challenges were regarding the graders, right? So means if the grader is a fresher. Right, and if a grader is in means experienced medical retina or the surgical retina guy. So we kept grading to be done by 2 expert and 1 by the fresher, right? And then they are grading it. It comes back to us. Again, we are grading it to rule out the differences, right?
How do you clean the capture? If
Sorry?
the capture is not good.
Yeah.
Do you have anything to clean it?
Delete it.
Yeah, we have a lot of applications in that. Zooming capability is there. Brightness and contrast slider is there.
Now, suppose it's a little defocused or that kind. Usually that's...
If it is defocused, we can't help it because 5% of our images we have studied, we have graded over 2 lakh images, right? So 5% we were unable to grade after doing each and everything, whatever it's there. 5% we can't grade. Thank you.
Thank you so much, Dr. Maurya. Yes. Dr. Avdesh, inviting you to give your talk on new needle for suprachoroidal triamcinolone acetonide injections. In the meanwhile, Dr. Surbhi Agarwal, please be ready with your presentation, Best Out of Waste. When the discussion is going on, I would request the next speaker to just load the presentation and keep it on so that we can save time. Yeah, timer is on. It's very hot.
May I start? Good evening, everyone. This is AT21 new needle for suprachoroidal triamcinolone injection. I am Wing Commander Avdesh Oli. So management of macular edema is done by topical drops, and in chronic cases we require intravitreal injections, and steroid implants are used, but they are costly. And suprachoroidal injection of preservative-free steroids is a recent addition to our therapeutic armamentarium. Though the preservative-free drug is commonly available at a reasonable cost, but the micro needles and catheters are patented and they are not commonly available. So we modified a 26 gauge needle with a 22 gauge intracath cannula for safe and cost-effective delivery. So this is the needle which we devised, wherein you can see this is the outer sheath of the cannula, which is on the 26 gauge needle, and the anterior 1 millimeter has to remain exposed, and the injection is given 4 millimeters from limbus, like a intravitreal injection. This is a short video of the procedure. Video is not running.
AV team, just please check why the video is not running. Can you please explain it in the meantime?
The timer,
AV
please
team,
pause the timer.
Yeah,
Timer
please
is going
pause
on.
the timer. Please be here only so that their time is not wasted. Just play the video separately.
Okay.
We have used inexpensive intracath and a 26 gauge needle to give suprachoroidal injection effectively. So you can see we, with the help of a scissor, we cut the sleeve of the intracath to almost half the length, and then we put it as a sleeve on a 26 gauge needle, and it goes freely into the needle. But you have to take care that terminal 1 millimeter of the needle should be exposed outside. This is reconfirmed with the calipers because terminal 1 millimeter should remain exposed. Now, like for any standard injection procedure, we put a drop of betadine and we mark 4 millimeters from the limbus. And after putting paracane, we take this needle, we have to keep the needle perpendicular to the sclera, and we have to apply gentle pressure so that there is a slight dimple is formed, and effortlessly you can inject the drug in the suprachoroidal space, and with the help of bud you can prevent the reflux.
I'd request all the speakers to please check your presentation there so that these problems don't arise.
So we tried this injection in 20 patients of macular edema with that is pseudophakic CME. The mean duration of topical treatment was 13 weeks, and the visual acuity and macular edema reduced in these patients from almost 453 to 255 microns, and the intraocular pressure during the follow-up period was normal. There were no complications like endophthalmitis, retinal tear, or lens capsule damage. These are some of the representative anterior segment OCTs wherein you can see the drug deposited in the suprachoroidal space, and this is a 3D reconstruction of the OCT, and this is a UBM picture. If you look at the OCT on day 1 itself, almost 50% of the intraretinal cysts, they have flattened, and the retina is pristine at the end of 1 month. So this needle is cost effective and safe for suprachoroidal triamcinolone injections. And looking at the merit, this was also selected for presentation in a Shark Tank session of VRSI, and it has been published in Indian Journal of Ophthalmology. We are happy to share that now this technique is being applied world over. This is one of the papers in European Journal of Ophthalmology which have duly acknowledged the technique, and this is our step towards Make in India and Atmanirbhar Bharat. And we want to keep it open source for mass usage without any patents, because Har ek kaam desh ke naam. Thank you.
Thank you.
Very nice. One question is regarding post, after giving the injection, do you do an indirect to see?
Yes.
Immediately?
Immediately, yes.
Okay.
The story behind how this all happened.
The development of the injection, sir.
Yes.
So there was one patient during my fellowship in LVPI whose image once I had used in AIOS, and I had one iPad for the best image. And I always used to have this comparison of iPad and Ozurdex injection. Their costs are almost comparable. And when a poor patient comes even to my practice or otherwise, they pay roughly 30,000 rupees for an Ozurdex. So I always used to have this kind of comparison that we need to do something which is very, very commercially viable for these patients. Then I was studying about these suprachoroidal injections. I always used to get fascinated. Then suprachoroidal buckles. And then once I was doing SRF drainage with a needle, 26 gauge needle, and I was very, very particular that I should not over penetrate. So I wanted something which could be guarded. And I did SRF drainage with that guarded needle that day. Then this idea struck to me that it can be used for various procedures. Like even some years from now, we could be doing dropless cataract surgery if you use the same technique. There are some ethical issues to it, but you give a suprachoroidal injection with cataract surgery and the surgery would virtually be dropless. And there are multiple applications which would be coming to this.
Did you do any validation between the commercially available long-term steroids?
So the commercially available, the steroid implants which we have, Ozurdex, dexamethasone, that is a different compound altogether. And but triamcinolone as such for suprachoroidal route is not available commercially out of the trial in India at least. So we could not do a head-to-head comparison. But with Ozurdex, we have not seen such a dramatic response on day 1. It could be because that it's a depot injection and slowly the drug is released. But this effect of this is actually miraculous on day 1 itself. And by end of 1 month, the retina is absolutely flat.
The other thing I want to, why not just bend the needle tip at 1 mm so it will act like a guard instead of putting in a sleeve?
But sometimes if the angle is not accurate, sir, then it could go and then it will be an intravitreal injection that maybe sometimes may not be warranted. Because if the more needle you penetrate, because there is hardly a difference of 0.1, 0.2 millimeters there.
If you bend it exactly at 1 millimeter, then
But
it cannot penetrate more than that because it's a simple, just a bend in the needle.
But that guard, that exact guard will not be there, sir.
The guard and the bending.
The bend will act as a guard.
But I don't know, we have to look at the resistance and fluid dynamics. Maybe I'll try this in some posts in eyes, but that fluid dynamics will happen.
Did you check for the intraocular pressure compared to the Ozurdex?
Sir, over a follow-up period of 1 week, 1 month, it is absolutely comparable. But what I have noticed that immediately after the procedure, sometimes the IOP could be high. So I have even checked intraocular pressure immediately after the procedure at 5 minutes and 1 hour and 1 day. So there is some elevation at 5 minutes and 1 hour, and those patients, they can be given with just a tablet of Dimox and they are fine. At 1 day, the pressures are absolutely normal.
The bend will not work, Sri Ganesh. The bend will, I'm here. The bend will not work because your bore will be facing straight. So your penetration will penetrate the sclera, but your bore which injects the will not work. So don't try to bend. It's not going to work.
No, you are assuming that.
You are assuming that when you bend there will be a kink, but if you are able to bend without a kink.
No, the bore.
No, the bore.
The bore of the.
Yeah, bend will not work.
One more. How do you measure this 1 millimeter? What do you use? This or regular caliper, or is it a more sensitive caliper?
Regular calipers.
You always get 1 millimeter because it varies. With
Because the bevel of that needle varies from 900 microns to 1100 microns. The general rule could be that you just you leave the beveled end uncovered. So it would be roughly around 900 microns of a particular make, the needle which we
are
use.
already short of time. Thank you so much, Dr. Avdesh.
Thank you.
Can we have the next speaker? Judges, please note you have to give marks to all the speakers. Dr. Surbhi Agarwal would be speaking to us on best out of waste. The next speaker, Dr. John Davis, he would be, please keep yours ready on pocket fundoscope. And then Dr. Prithvi Chandrakant would be there. Yeah. Please start.
A very good evening, dear judges. I'm Dr. Surbhi Agarwal from Shankar Eye Hospital, Bangalore. I'm going to share with you today our innovative DIY chandelier, which we made out of waste products available in the operating theatre. So our story started with a vitreous hemorrhage that we were planning to operate. We were expecting it to be a quick swim in the ocean like this. But when we encountered this, our reaction very quickly changed. So what is the obvious next step in a tractional retinal detachment? We asked the sister for a chandelier. But maybe like us, you are also facing the same problem always. Instrument is not available. Chandeliers are expensive and usually only a few pieces are available in each OR. And if they've been used in cases prior to yours, they may not be available for your surgery. So we thought what alternative to chandelier we could use to provide illumination during our surgery. Maybe modify a light pipe in some way because it was definitely not possible to use a second light pipe in the way it is already. So for that, we decided to remove the outer casing of the light pipe or the probe of the light pipe. And then what we did was we stripped the cable of the light pipe. So this exposed the fiber optic cable. Now this fiber optic cable could easily be placed into the trocar and then it could be glued like how we normally glue a chandelier in the gooseneck loop. But the problem was that an infinite amount of this fiber optic would enter the eye and probably cause a retina touch. So we needed a stopper of some kind, like how it is there in commercial chandeliers, so that only a small amount would enter the eye. But how to make a stopper? We decided that we need a easily available material in the OR which can be sterilized or is available in sterile format. So we used a buckle for the same. So what we did is we took a small piece of the buckle, made a fine hole in it using a needle and threaded the fiber optic through that. And here our DIY chandelier is ready. So here we are making it in one case. In this case we have used a 240 band. We've cut a piece of the band, making a hole in that, threading the fiber optic through that, and then placing it in the trocar and securing it as usual. This is one of the surgical videos where we've used the DIY chandelier. We can see the surgeon is doing bimanual surgery, forceps in one hand and cutter in one hand. And in spite of the presence of a slight cataract, the view is quite diffuse and clear for us to do the surgery. This is another case where we've used this bimanual chandelier. Bimanual surgery is being done in a diabetic vitrectomy and the adequate illumination can be seen. So our chandelier can be placed and fixed in a cannula which is similar to standard instruments. The area and intensity is comparable to commercially available products. So we had 3 independent vitreoretinal surgeons assess this chandelier in their cases and tell us how they felt. So all of the surgeons felt that the chandelier was easy to make, easy to secure and easy to remove, and the ease of use during the surgery improved as the number of cases of the surgeon with the chandelier increased. So as compared to commercial chandeliers which may cost anywhere between 6,000 to 12,000 rupees, our chandelier is absolutely free of cost. Since the fiber optic is thin and the stopper is broad, it can be used for both 23 gauge and 25 gauge systems. And using waste material available in the OR, we virtually have an unlimited supply of emergency chandelier. The disadvantage is that because of the black tubing, there is limited globe mobility during the surgery. There is a theoretical risk of lens or retina touch by the protruding part. However, we did not face this problem in any of the cases that we used the chandelier. And definitely, even though the chandelier is DIY, the need for a second light source is there. Of late, we have been using it with a LED light source, and that already has 3 ports for illumination, so we don't need a second light source as such. So take-home message, creative thinking can help us to overcome any crisis situation, not just in terms of surgical technique, but also in terms of surgical instrumentation. We are not saying that we should replace the gold standard, which are the commercially available chandeliers created with thousands of dollars of research. However, this is a good chance for us to adapt to adverse circumstances. Thank you so much.
Very nice presentation. Question is about the stopper.
Yes,
Are
sir.
you gluing it at one position, say only 2 millimeter should go in, or is it flexible?
No,
Does
sir.
it move?
We are putting it 5 mm because the goiter chandelier that we are using, the commercial chandelier that we were using, has a 5 mm tip. So we measured that and we are putting it at the same distance in our chandelier
But
also.
does it snugly fit in?
Yeah,
With the movement of this,
we
it might
make
go in
it
and
using
out.
a 30 gauge, we make the bore using a 30 gauge needle, so it snugly fits. So we've not faced this complication in any of our cases. However, we do have a solution for it. So we've tried this with a double stopper, so it increases the resistance. The other option is to use cyanoacrylate glue, which is anyway used for medical reasons. It's used by our anterior segment colleagues for corneal ulcers, and that is medically safe. Also resistant to sterilization by both autoclave and ethylene oxide, so that can be used for this purpose.
Yeah, the idea is good.
Thank you, sir.
You still call it it's free?
So made out of waste materials, except for the 30 gauge needle cost, I would say that everything else, that we've used a broken light pipe, we've used the remnant of the buckle which was used in the surgery. 30 gauge needle was fresh, sir, that we used.
Band also will cost, no?
So band, when we are cutting a tire for surgery, usually small pieces left over, that we've used.
Originally it is costly, but very good idea.
You can label it as 5 rupees.
Don't say free. And will it come out in between if you turn the globe? Will it get pulled out?
No, sir, that's what we do with the normal chandelier. So we make a gooseneck thing and then we suture, stick it. That's what we do with the infusion also. That's what we are doing for this also.
Thank you, Dr. Surbi. A very nice presentation.
Thank
Congratulations for being selected. And
thank you.
Yeah, thank you. Dr. John, inviting you for your presentation on pocket fundoscope, 3D printed foldable, ultra portable smartphone fundus camera. Dr. Prithvi Chandrakant, please be ready with your presentation on slit lamp based intraocular lens microscope.
Okay, so I'm going to present on Pocket Fundoscope, which is a 3D printed, foldable, ultra-portable smartphone fundus camera. I'm Dr. John Davis Akkara, and I'm from Western Eye Hospital, Cochin, and also in Chaitanya Eye Hospital, Kochi. So, financial disclosure, I have a provisional patent for this invention, and I hope to have commercial and financial interest in this device. We know about the evolution of computers, starting from abacus to ENIAC, the big machines, the desktop, laptop, tablet, then smartphones, and finally smartwatches. Do we know about the evolution of fundus photography? So first there were this low quality images taken by huge devices, which slowly improved in quality, and the devices were even more huge, and it was very expensive. Then now we have the large desktop fundus cameras, the smaller ones, and also the smaller portable fundus cameras. Then we have the dawn of smartphone fundus cameras. So we have the commercial ones which have the options of non-mediatic as well, and the low-cost ones which are mediatic. Now my target is frugal innovations. So there are some 3D printed fundus cameras, one of which I have designed. And in addition to that, now my thing is to go to the next level with this frugal innovation. So it's a fantastic future of phone fundus photography, a foldable fundoscope. So this is a smartphone fundus camera, which is foldable, fits in your pocket, fast to unfold, and it can be used by anybody who knows how to use a smartphone fundus camera. How did I design this? First, I learned how to do 3D modeling using CAD, and then I used 3D printing for prototyping the designs. So then I tried out some designs, and this was one of the later models. This is how I designed it using the FreeCAD software. These are the models which are folded, unfolded, all that. I've drawn these myself. And then after that, I've 3D printed it. And this is the model. You have to put a 20 diopter lens inside this, which can be replaced with another lens. We can put a smaller diopter lens by changing the adapter inside that. This is a lens case. This acts as a lens case also. It protects the lens. This is a folding joint, and this acts as a half of the lens case. And that is a folding joint for the phone attachment. The phone attaches here. And this works exactly like a smartphone fundus camera. You can unfold it, and then take a fundus photo using your phone. And if you have used smartphone fundus cameras, you know that it depends on the phone's quality, the image of the camera, and also the technique. But if you know how to do it, you can get very, very good photographs, and you can use a phone software to make it look like a commercial photograph, and you can print it and give it to the patient. These are some of the photographs taken with this device. These are all taken with this device. And if this left photograph is taken with a Zeiss fundus camera, and this is a comparison of the field, it's a little less than the Zeiss camera, but if you change the lens, you get a bigger field. It's low cost, ultra portable, because all the other ones cannot be put into a pocket. And that last mile of putting it in a pocket and going around, that is preventing many people from using the smartphone fundus cameras, which they have bought and kept it in their clinic but not used. This is going to solve that issue. I hope that all postgraduates, residents, fellows can use this. So this is perfect for all cost-conscious ophthalmologists. And I have a patent pending, and I hope to have it worldwide soon. Thank you.
Fantastic.
Thank you so much, Dr. John. That was really astounding.
Dr. John, what is the cost which is coming up?
So 3D printing has a cost based on the material used. If you go, you go to a commercial 3D printing shop and print it, it costs 840 rupees.
Wow.
But I'm not going to sell it for 840 rupees. I'm going to sell it for more because I have a patent. So 4,999.
Achha, any of the what we say fundus, this thing, smartphones fit in it?
All the smartphones. There's an adapter. You can put any smartphone up to 6.4 inch size. So that is, except the large Ultra Pro, Max Pro versions, every other smartphone fits into it.
How much degree of the fundus is covered in this?
So that is slightly, I think it's 40 degrees, slightly less than.
And you definitely require full mydriasis.
Yes, we need full mydriasis for this model, but in the patent as well, I have plans for a different illumination system which avoids the need for full mydriasis. That would be a slightly modified version of this. That is
for
in the works. This is mydriatic.
90 degree and 78 degree let's say lenses, the adapter, sorry. Have you used it and seen the amount of clarity and the...
The 90 diopter lens doesn't work for this length.
Okay.
I have used 90 diopter lens for taking mouse fundus photographs.
Okay.
Because the size of the eyeball is different. This works with 2.2, that is 22 diopter, that is 2.2 pan-retinal, works with 28. Those three I have tested and it works.
Thank you. Fantastic.
I have one quick question. The fact that it can be put in a pocket is a very important thing. But if you put that aside, how do you rate this as against the other commercial ones which have been around for a while?
So quality wise, it gives you exactly the same quality as all the other smartphone fundus cameras, because right now it doesn't have anything other than the lens and the smartphone, which holds, practically that is what it is. But I have an illumination system which will avoid the glare, which will allow you to take at a lower mydriasis. That is, if you have a small pupil, you need the illumination system to be inbuilt in this.
Right now, this is just a spacer, right? It's just a spacer.
Right now, this is working for mydriatic fundus photography.
It's just a foldable spacer between the 20D and your smartphone.
As all the other smartphone fundus cameras are.
You can also hold it in your hand.
Which is not very comfortable.
Which is not very comfortable, but it can
People
be
are
done
doing that.
if you have steady hand. So this is just a spacer as of now. If you can have a coaxial illumination system, okay, then I think this device would score because you can get good quality. Otherwise, you can hold it with your hand and take it. It's just
with your hand, it is not easy. Anybody who has attended any smartphone fundus photography class or tried it themselves will know that holding it with your hand is not easy, except for some people who have very steady hands for this. I do that. I've tried teaching people. Many of them cannot do it, just cannot. With the adapter, they can do it. With this adapter, they can do it, put it in their pocket, go. I want all postgraduate students and fellows to have it in their pocket, go around, take fundus photographs, store it, save it, document it, send it to their seniors, get opinions, publish it, all the works.
The other thing is if you can add a spacer from the bro,
Yes.
it will become much better because it steadies the lens on the bro.
Right.
So I would suggest you add a spacer so it doesn't move. Otherwise, holding the device, you have fatigue on your hand and it can move. So if you have a spacer which holds it on the bro,
Yes,
then
sir.
it's steadier and then you get better quality photographs, and you have to have a stereocoaxial illumination system which will improve the illumination of the...
Yes, sir. That is in the patent.
Two more questions is, sorry. One is the weight of this thing is how much is it? The way Sri Ganesh just said.
So this is a rough model. This is a
Very
model
light,
which
very
I
light.
drew.
You can make it out of carbon fiber.
And this has a lens inside.
Okay.
This is with the
Lens. Okay.
And in fact, this is the heavier Nikon lens that I have rolled it. And
you make it out of carbon fiber, it will be lighter.
Still lighter.
It will be smaller. It will be all curves because curves cell rounded rectangle.
Can you make it with telescopic pipes going one in the other?
I tried
To make it even
telescopic,
lighter.
but rather than telescopic, I settled on this model in the end. I tried telescopic models. In fact, there are 3D printed telescoping swords. So I used that model to try and make one, but it is not stable. This is very stable.
Yeah. Do you require a...
It doesn't. It is proper solid.
In all mobile phones, you require a specific app to have what Dr. Sri Ganesh just said. Any smartphone you can just pick up
Not
the images.
required.
Require a continuous illumination
The
and a flash on.
regular camera app in video mode with flash on works. If you want to use an app, you
Dr.
can use
Prithvi.
MI Redcam app. You can use the. There are a few other apps which you can use.
Thank you. Sure.
Not
Thank
required.
you so much, Dr. John.
Thanks a lot.
Thank you so much. That was really nice. And after Dr. Prithvi, Dr. John, you would be speaking again on designing and making 3D printed glaucoma drainage devices. Okay. Dr. Prithvi, please start your presentation.
Slit lamp intraocular lens microscope. We all know in a busy OPD, we come across corneal ulcers like the one you can see in the video, which might also involve the visual axis and be very difficult to treat. And we all know the treatment cannot be initiated without a corneal scraping, and hence is an important part of management. Normally, we use a Kimura spatula to get the scraping from the lesion, and then either we check it in the microscope or it is sent to a microbiology lab if you are in a big institution. And depending on the diagnosis of the pathogen, the appropriate treatment is started by the clinician. But not many do the same. They start the patient with a cocktail of antibiotics. Listening to the whole cumbersome process, don't you think it's lengthy and tedious? Hence, the procedure, especially in clinics like vision centers and PHCs where a microbiology laboratory is not always available, this process becomes difficult and the treatment delayed. And that is where we need a point of care testing where it can be portable, lower cost, have faster processing time, and also reduce the sample volume. That's when we found AIOS, an intraocular lens-based microscope, a perfect innovation tool made with minimal resources for point of care diagnosis, especially for cases like corneal ulcer. In this video, you could see how an AIOS is made using 4 intraocular lenses of 30 diopter lens attached to a chart paper with liquid adhesive and then attached to a smartphone to carry out examinations of microorganisms. Then we thought, why not make IOL scope specific to an ophthalmologist by attaching it to the slit lamp with a mobile adapter, also using a torch for illumination. So introducing you to SLIM. As you can see in the video, the illumination part of the slit lamp is detached from the pivot joint and the smartphone adapter is attached to it. Once it fixes properly, we need to reattach the illumination part into the slit lamp. And this is the part of the adapter where the smartphone will be fixed. And here you can see how the joystick can be used to move up and down and sideways. You can use a torch for illumination, or we can even make your own illumination tube with any hand sanitizer bottle and a smartphone with a flashlight on. And once you keep the slide on top of this bottle, you can examine it with the SLIM. This video shows the application of SLIM in a patient with corneal fungal ulcer. The doctor can be seen doing on-spot diagnosis of the corneal scraping using the smartphone-based AIOS scope and accordingly giving the appropriate treatment, which results in better patient counseling, faster treatment, and prevents delay of diagnosis. It is not always necessary to dismantle the illumination part. Pivot joint has an extension. It can be simply attached to that extension and the examination carried out. Hence, SLIM, an attachment of the AIOS scope to the slit lamp biomicroscope, is an innovative, novel modification to an existing slit lamp, transforming it into a microscope.
It was an excellent presentation.
Thank you.
Debashish sir, your comments?
Some photographs of the microbiology photographs.
Yeah, there's a few photographs in the video itself.
Hello everyone.
Yeah, these are few images of the AIOS, images taken from the AIOS scope, and I also have a physical poster happening tomorrow. I have compiled all the images of the study which I've done in that. So for now, this is this.
Did you compare the quality?
Yes, sir. Yeah, exactly. Yes, sir. That's exactly what I did. That's what is selected as a physical poster. And
what did you find?
Yeah, KOH mounted slides, we've got around 92% of sensitivity in finding the fungal hyphae. And if it's a cultured media, then we get it 100% of hyphae is detected. So that's the sensitivity part of the AIOS scope.
How many AIOS you said? 3 or 4?
Yeah, actually, so in the beginning, this was at the beginning which I did. So that was 4 30 diopters lens, which PMMA, rigid lens, which was kept one on top of the other and glued with the liquid adhesive and taken photo. But now we have developed with the Orolab, we have developed one single lens, which comes up to 120 diopters. Yes. This comes up to 150.
Okay.
Yeah, so we found we made it to 200, 300 too, but then there was a lot of aberrations because of the spherical convexity, and we found 150 was the best. Okay. And even the distance between the slide and the lens also matters. Where in the one which we saw over here, 4 diopter lenses, it was around 2 to 3 millimeters of gap. But while designing this, we made it into more 5 millimeters, around 5 millimeters. Also, the aberrations due to 4 intraocular lenses has been considerably reduced in the one which we are using right now.
Quite right.
Is the illumination adequate?
Yeah, illumination, we need an external illumination. So either you can use a smartphone, another smartphone, or you can use a torchlight itself. The AIOS scope in the IGO innovation section, we have already published and on how to use it. So we can just keep the torch standing and keep a slide on top of that, and you can just use it freehand like this. But then you can even make tubes like this. Doesn't cost much. It's like a hand sanitizer again, and which is connected with 2-3 LED lights below, and you can even keep a platform for slides too. So. And making this is really easy for consultants and clinicians who can just put it into the slit lamp and start seeing for the fungus. Yeah.
Is the Orolab available for 150 diopter?
No, we are not commercially. Yeah.
Okay.
Thank you, Dr. Prithvi. That was really good. Congratulations for being selected as a finalist. So Dr. John Davis for his second talk on designing and making a 3D printed glaucoma drainage device. The next speaker, Dr. Shivraj Tagare, please be ready with your presentation. Is he
Designing
here?
it. So this is going to be a video. After the video, I'll just show you a screenshot also.
designing and 3D printing novel glaucoma drainage devices, Dr. John Davis Akkara, Dr. Narayan Balakrishnan, and Dr. Anju Kuriakose. The authors have no financial interest in this presentation.
I'm Dr. Narayan Balakrishnan and I am a practicing glaucoma consultant. My colleague, Dr. John Davis, and I have attempted to make an innovative glaucoma drainage device that can be implanted in animal eyes to practice implantation of this device and help in future implantation of glaucoma drainage devices in everyday practice. The implantation of glaucoma drainage devices very difficult and require a long learning curve, also very expensive, and hence it deters young ophthalmologists from buying them, practicing them, and then using it in human eyes.
I am Dr. John Davis Akkara, glaucoma consultant. I used 3D computer aided design and 3D printing to design and print the glaucoma valves that we are talking about. So I used a free software called FreeCAD to do the design of the valve which I had in mind. And once I had drawn the design and finalized it, took it to our 3D printing lab in campus and used the resin 3D printer to print the model. I used the tube from a Venflon to make the tube of the valve. It was inserted into the hole of the foot plate, and so this is the foot plate, and that is a tube that is inserted into the anterior chamber or pars plate. We also injected fluorescein dye through the tube to see the flow of aqueous into the see the air bubble which block the canals first. So even a single air bubble can prevent proper drainage. We then fixed a bow tie in a plastic container and did a conjunctival peritomy. The foot plate of the GTD is carefully inserted under the conjunctiva. Make sure that the conjunctival opening is big enough to accommodate the foot plate. The foot plate has a larger surface area than the cornea. The tube is left pointing upwards towards the cornea. The foot plate is then anchored to the sclera by suturing through the holes. The tube is then measured and trimmed with the scissors in a bevel shape. We have to make a track using a needle, partial thickness through the sclera into the anterior chamber in case of a phakic eye, and into pars plana in case of a pseudophakic or aphakic eye. So now that partial thickness tunnel has been completed, then next step is to insert the tube into the tunnel so that it reaches the anterior chamber. Once the tube is inside, we have to make sure that it does not touch the endothelium. These are some of the other glaucoma drainage devices that we had printed compared to the first one, which was quite big. We 3D printed 3 different shapes and sizes of non-valve GTDs. Hope this innovation with 3D printing inspires young surgeons to start doing glaucoma valve surgeries and also to design newer models of glaucoma drainage devices. Thank you.
Thank you, Dr. John. Just for your information, we have 3 more talks and 10 minutes. So I think we'll have to be a little quick with the questions. Yes.
What is the material of the foot plate that you are using?
So this is resin, 3D printing resin, UV sensitive 3D printing resin. There are 2 basic types of 3D printing which is easily available. One is this resin 3D printing, other is filament 3D printing. Filament is the one which I use for the fundoscope. That is, you can have plastic or related materials, polymers. This is UV sensitive resin.
And size of it, the foot plate? 3 millimeters, 2 millimeters, okay.
You can design whatever size you want.
Okay.
This is the smaller one which I designed, this is the bigger one. Basically, I am designing this so that this can be used in the wet lab. Right now, this is free, open source for the wet lab, not patented. This can be downloaded and printed from Thingiverse as of now. It is going on the NIH 3D print exchange as well. So you can download this in ask them to print it, and then you can use it yourself. It will cost, printing all these together, it will cost maybe 50 rupees. It's based on the weight.
Great.
Very nice.
Thank you, Dr. John. That was really great. Can we have our next speaker, Dr. Shivraj? Tagare. He would be speaking to us on incremental innovations in eye care. Our next speaker, Dr. Kunal Mandlik. Please be ready with your presentation. And then Dr. Prithvi Chandrakant once again. Please start your presentation.
Anterior stromal puncture for toric IOL. Errors can occur while marking associated with smudging or fading away of dye during pre-operative reference axis marking. Anterior stromal puncture creates a point mark without any epithelial erosion, and the simultaneous staining helps in perfect and long-time retention of the dye. Thus, ASP stain stays for more than 48 hours. Low-cost, high-definition Raspberry Cam. Raspberry Pi camera is a fully functional Linux-based computer that can be fitted with a HD camera module. An adapter, which is portable and also small enough to mount the Raspberry Pi, can be fitted to the Observer eyepiece. It has a better quality than the more expensive commercially available systems like conventional camera, and mobile phones is more portable and records videos in high resolution. 5-cent airway for patients to breathe easily during surgery. The lanyard that is thrown away after each conference can be reused in this manner. The one end of the lanyard is tied to the microscope and the other end is clipped onto the drape during surgery. It also has a sliding note to adjust the drape height. COVID-19 safe intubation hood. A simple structure made from PVC pipes and plastic sheets. This intubation hood will minimize the spread of microdroplets and aerosol while intubating and extubating the patient. OT trolley sanitizer dispenser. It is portable and foot pedal controlled. It helps in hand sanitization by the OT personnel at frequent intervals. Spring action apparatus for fixation of eyeball is a robust, simple and economical device to solve the problem of achieving a formed and firm eyeball which is stably fixed in a holding device in surgical wet lab training. The spring action syringe generates vacuum and enables reliable fixation of human and animal cadaveric eye on the iron cylinder. The rise in intraocular pressure due to vacuum fixation can be varied as per need or nature of surgery. Magnifier screen. Magnifier screen is a simple tool that can be used to read fine prints of automated printouts and match IOL labels before cataract surgery without using presbyopic glasses, microscope simulator or simulator box. To avoid the confusion for patients to focus on the light during phaco and flax and help them focus, we have devised two simulators mimicking the light source of operating microscope and flax laser, which are shown before surgery to help the patients to know what they see and what they must focus.
So good evening. These are some
excellent presentation.
Simple solutions to problems that we face every day in OT. Like sometimes we just go along with it. We don't think it's a problem because we can solve it. But for in the longer run, it is not good for the patient as well as the doctor. So these are some just simple solutions to counter these problems.
Now in these, which all were you involved in this? You have been involved in all these?
No sir, it's a team effort sir. Many people were involved in making all this.
What's that magnifier that you had for
Yes sir,
seeing the biometry?
It's a Fresnel prism sir. So it's for this presbyopic surgeons just to magnify all this.
I think that you can relate to it very easily. Okay, can we go on to the next speaker, Dr. Kunal Mandlik, please. The speaker after that, Dr. Prithvi, please be ready with your presentation. Yes, please begin.
A pterygium is a wing-like growth of degenerative subconjunctival fibrovascular tissue that crosses the limbus and encroaches the cornea, causing ocular irritation, inflammation, and poor cosmesis. Recent times have seen an upsurge in the number of pterygium excisions being performed. With the use of conjunctival autograft and fibrin glue, the recurrence rates have massively dropped. However, remnant pterygium tissue on the cornea can contribute to poor symptomatic relief and dissatisfied patients, not to mention the unacceptable cosmesis. In advanced and strongly adherent pterygium, dissecting it off the cornea can prove to be quite a task and one may end up with inadequate dissection and remnant tissue over the cornea, resulting in poor cosmetic outcomes and uneven ocular surface, thereby rendering the whole procedure futile. An effective solution for this is the diamond burr, which aids in the removal of densely adherent pterygium tissue and smoothens any surface irregularity. It is an indispensable tool, and inevitably it comes with a price. A commercially available burr can cost anywhere between 68 to 75,000 rupees. We at our institute have designed a much cheaper but equally effective alternative to the commercially available diamond burr. The raw materials required to build this are a 50cc syringe, a switch, a motor, a 9-watt battery, and a burr tip that is used in most commercially available burrs. The 50cc syringe is dismantled and the plunger is separated from the barrel. A window for the on-off switch is cut out in the syringe barrel and the needle adapter is also cut off. A motor to power the burr is inserted first into the syringe, followed by the 9-watt battery. The switch is now lodged into its opening in the syringe tube, where it fits snugly. This arrangement is held in place by closing the tube with a plunger seal. Finally, the burr tip is attached to the motor by placing it in the position of the needle adapter. The burr is now ready to be used and is turned on and off using the power switch. A steady flow of balanced salt solution is injected while the burr is used on the cornea to dissipate the heat produced. The rotating action of the burr tip loosens the densely adherent tissue of the cornea, thereby facilitating its easy removal and smoothens any surface irregularity caused by the thick pterygium tissue. The post-operative outcome is a smooth, even corneal surface without any residual pterygium tissue. This ensures complete symptomatic relief as well as a desirable cosmetic outcome for the patient post-operatively. The cost of this alternative is under 3,000 Indian rupees, a fraction of the cost of the conventional burr.
Excellent. What is the sterilization of this? Reusable or not?
Yeah, it is reusable, sir. We do ETO for that.
Okay.
So main problem with the surgeons not using the commercially available burr is the cost. That main cost of the burr comes from the main motor and the motor piece, whereas the diamond burr tips come to around 1,500 or 1,200 like that. So we try to replace the motor part of the burr with this low cost burr. So this motor is a regular 12-volt motor which gives an RPM of around 2,700 to 4,000 RPM. So we are still making one more design is there. So we are putting a regulator like the thing to control the RPM also. So it's still under process. And this we are regularly using in our patients, daily patients with no complications.
How much is the life of this?
It depends on the products and 12 volts battery, how long it will last. It is replaceable. It's very cheap.
Okay. Thanks.
What is the end point?
Thank you.
End point of the grinding. What is the end point of the grinding? Whether it is the diamond tested one or yours.
Main aim is smoothing the surface till we get mainly we use in very adherent pterygium tissues which are very hard to remove it using the crescents or anything. So those tissues can be easily removed using the diamond burr. Same endpoints as where the commercially available burrs are used.
Correct.
Nothing different, sir.
How sturdy is it? Because it looks quite flimsy. I mean, does the parts
no, sir. We are using it since 1.5 to 2 years. It's very sturdy, and the tips also the tip also snugly fits in, so there is no chance of loosening or anything. The head of the motor is around 3.17 mm. The head which goes into the tip, that also very snugly fits.
The switch that you have is too further down. Why can't you have it usable because you're holding the syringe this way?
Yeah, yes, sir.
The switch is up, it's way up.
It can, because of the ease of use. So when we have the switch up, so we can easily hold it like a pen, like a phaco probe. If we keep it like here, so some doctors might have difficulty in holding properly. Like we have difficulties in using heavier probes of different machines like that.
So you continuously put it on and use it, and then you take it.
Yeah, the other model which we are designing, which we have already we have put a regulator in it, so to control the RPM also. So that also we are in.
The commercial one is.
is right down there, so you can switch off, switch on easily while you are. So I think that's what.
Yeah, that also will.
Yeah. Thank you, Dr. Kunal. That was really nice, and congratulations for being selected. So we have the last talk now, Dr. Prithvi Chandrakant. Yes, please start your presentation. Yes, welcome, Dr. Chitra ma'am.
We have brought to you the Smart Scope Kit, a must for every ophthalmologist. A kit which consists of every small tool needed for diagnosis from anterior to posterior segment with the help of a smartphone. For examination of the visual acuity, we have a smartphone-based Snellen chart which can be downloaded from the Play Store or the App Store. We have a trial frame with a occluder and a pinhole, and also a +10 diopter lens. Hence, we can have a preliminary examination of visual acuity of patients with these instruments. Next range of instruments are for investigations. As you see, the most important is the torch. The next is a BP apparatus, a pulse oximeter, a syringe and a cannula to check duct patency, a glucometer, dilating and anesthetic drops, hand sanitizer and wipes, fluorescent strips for corneal pathologies, forceps and sterile 26 gauge needle for foreign body removal. We also have sterile histopad slides and spatula for corneal scraping, sterile gloves for safe examination. Now we move on to the range of anti-segment examination tools. The first is the eye verter for lip diversion and examining superior tarsal conjunctiva. The ASPE or the anterior segment photography using intraocular lens for smartphone based anterior segment examination. Shiot's tonometry for IOP measurement, and ASPE gonio for examination of angle structures. We also have IOL-scope, a IOL based microscope for smartphone based detection of fungi and parasites. The posterior segment examination tool include the Trace to Treasure RedCam for fundus examination using dilating drops. This kit comprises of frugal do-it-yourself tools required for basic examination of patient from anterior to posterior segment. It is smartphone based and helps us in storing images, videos, helps us in teleophthalmology for expert opinion and for resident learning and teaching. It is easily portable, it's a do-it-yourself, cost-effective, universal kit which can be used in peripheral centers, local clinics devoid of expensive equipments. Also, it's ideal for examination of patient in outreach camps. Thank you.
Would like to say a few words to all of you. I think it goes without saying that has been an amazing, enthralling, unique program in this hall, and to have been part of this kind of a very innovative thinking, the genius in each of you, which got exposed. I think it's a rather rare gift of that out-of-the-box thought process which all of you have displayed over the course of the day. And I think I would be failing entirely if I do not wish all 45 of the Think Under the Apple Tree participants for the humongous contribution to this very great program. And of course, all of them have been great, but kudos to the finalists for getting there. A clap for them too. And the final winners of the event, which would be announced to you all on the at the valedictory function, which would be around 2 o'clock on Sunday. I would wish all of you are there, because there is some prize for the other which you all are getting, no? Which would be announced and which would be given next year. So 3 cheers to one and all of you. Hip hip hooray. Wish and pray that you grow from strength, to outbeat yourselves and come back again every single year with newer and newer innovative ideas. God be with you for an ever expanding, enriching, unique journey which you have all set out on, because I think it's quite rare. Not everybody could think the way you thought. Thank you, one and all of you. Thank you very much. And most importantly, I would like to thank all the judges who are present here for being so patient, being with me throughout the day, being very supportive for our ARC programs. And I would also like to thank all the judges who were there over the day, whom I have not seen, but I would especially wish them on the WhatsApp group. Thank you.
On behalf of the judges, I would like to thank Dr. Chitra, all your ARC members who have been there around the corner, and a fantastic idea of having this. It is too good, and we love to do the judging. Very interesting videos, absolutely out of the box. Thank you very much for this brilliant idea and allow us to be judges, all of us. Thank you.
Thank you to the convener and co-convener.
I would
Can
request,
we have a picture here?
all the judges and all the finalists, we'll take a photograph.